Now I'm going to discuss some cases. These cases came from my clinical practice, and I've merged a few different clinical presentations together into one story to de-identify the cases and for purposes of making various teaching points. Case 1. 7-year-old with long history of inattention, hyperactivity, and emotional dysregulation. Parents reported his 4-year-old sister can organize and plan more than he can. He had a medical history significant for seasonal allergies, a father with ADHD, and he was currently taking no medications. After a thorough review of symptoms, teacher report, and parent report, I diagnosed him with ADHD. I discussed with the parents that stimulant medication is the standard of care for the treatment of ADHD. We discussed the options for behavioral therapy, importance of exercise, and a healthy diet. Parents were hesitant to start stimulant medication as the father had a significant side effect in the past when he had taken methylphenidate as a child. Mom asked if starting an omega-3 or any other supplements could also help with symptoms. I agreed that an omega-3 supplement could be helpful and recommended 1 gram per day, of which at least 600 milligrams should be from EPA. We then discussed the risks, benefits, and alternatives of starting broad-spectrum micronutrients. We titrated as follows, with the aim of getting to 9 pills per day, as used in the MAEs trial. On day 10 of starting broad-spectrum micronutrients, parents reported some improvement. He seemed not to get as angry as easily. On day 15, the patient started complaining of stomach aches, so we reduced the dose to 3 capsules in the morning, 2 at noon, and 2 at dinner. On day 30, parents reported a significant improvement, no more stomach aches. Of note, I increased the dose more slowly than what was done in clinical trials to help with tolerability and to be able to detect what dose may be causing side effects if they emerged, which in this case they did. The next case is of a 19-year-old female presenting with emotional dysregulation for several years. She had been diagnosed with ADHD and ODD at age 10. She was diagnosed with PMDD last year after describing high amounts of irritability prior to menses. She currently is not taking any medication given previous side effects with stimulants. Main concerns were irritability, poor sleep, and a diet high in ultra-processed foods. I discussed with the patient the data showing improvement in children and adults with ADHD using broad-spectrum micronutrients. The patient was very interested in this approach. However, she was concerned with the number of capsules required with the daily essential nutrients product. I discussed with her that although the 2 RCTs for pediatric ADHD use the daily essential nutrients product, a newer version requiring fewer pills, Empower Plus Advanced, has been studied in patients with PMS, of which a portion also had PMDD. I explained that for adults, the dose of the nutrients in Empower Plus Advanced is below the upper tolerable limit except for nicotinamide. We discussed other potential treatment options, including starting an SSRI. The patient elected to start a 6-week trial of Empower Plus Advanced. Patient reported at 2-week follow-up some improvement with focus and attention, but a large improvement with mood, decreased irritability, and improvement in overall mood regulation. And subsequent follow-up at 3 months, the patient improvement in PMDD symptoms. Case 3. This last case is a 27-year-old ADHD and mood dysregulation. He's currently prescribed dextroamphetamine/amphetamine XR 15 milligrams. He states that the medication helps a great deal with focus, but that when he takes it, he feels more anxious and irritable. We discussed risks, benefits, and alternatives of the broad-spectrum micronutrients, and that although the 2 formulas have been studied in 3 randomized controlled trials, neither formula has an FDA-approved indication. We discussed the difference in the 2 formulas and what studies have been done in children and adults. Patient agreed to a trial. Over the course of 4 days, we titrated up the dose to 4 capsules 3 times daily. On day 7, he reported an improvement in his mood. On day 10, he reported feeling agitated and said, "Everything bothers me." As this fit the description and time frame of potentiation, I decreased the dose of the medication to dextroamphetamine amphetamine XR 10 milligrams per recommendation of the manufacturer to decrease medication dosage by a quarter upon signs of potentiation. During a phone check-in 2 days later, the patient reported an improvement in focus and mood regulation. About 2 weeks later again, the patient reported feeling easily irritated, and again the dose was decreased, this time to 5 milligrams daily. A couple weeks later, the patient during a follow-up visit reported feeling quite well, calmer, lifted mood, and still with good focus. He then decided to stop the stimulant medication. However, 7 days later, he called and stated that he was making careless mistakes at work and having a hard time driving and wanted to resume the dextroamphetamine/amphetamine XR 5 milligrams. This case again illustrates what I've noted in my clinical practice. In many cases, the broad-spectrum micronutrients are not a replacement for stimulants, but in many patients can help with mood and emotional regulation. This also reinforces the point that psychotropic medications can be potentiated with combined with broad-spectrum micronutrients, and therefore expert guidance is needed for cross-titration. Key points. Broad-spectrum micronutrients amplify the effect of stimulant medications. Therefore, close monitoring and expert guidance are needed when they are started alongside psychotropic medication, as dose reductions are typically required. Supplementation with broad-spectrum micronutrients often improve mood regulation.